The woman's 75 or 95 and she falls and she can't get up, not to mention a man. Why can't she get up? Age-related sarcopenia. She's weak, her legs are weak. Why aren't we treating this? There is an effect of the muscle building.
Yeah.
Why would we disparage it and discriminate it when we could use it? Again, I'm not saying steroids should be used by young men. I'm not saying that at all. I'm saying, why would we not look at the positive attributes? Alcohol is used.
Marijuana now.
Marijuana's not used now. We're missing the boat.
Because there's a stigma that it's just for vanity, aesthetics.
Absolutely. So the use and utility medically for these agents are as follows. TRT, testosterone replacement for hypogonadal men from 18 and above, right? And the reasons for hypogonadism are varied, including now anabolic steroid-induced hypogonadism, which is funny enough, by the experts in the world, they're finally listing it as an etiology for why you have low T. Otherwise, they're looking at diabetes, congenital, so on and so forth. Medicines.
Pituitary tumors.
That's right. The classic, everyone's still looking for that adenoma, that pituitary adenoma. Again, I'm not disparaging. This is all I do, so you see it over the course of 20 years as a physician, and like, that's interesting. And now you have to have the most common cause of hypogonadism in a man who's under 50 in America is from steroids.
Hey friends, welcome back to another show brought to you by our friends over at Joovv.com. They're the leaders in photobiomodulation, or light therapy. This is a tool that I've personally used to increase my testosterone levels. As you'll hear about on the show, as we take a deep dive into HRT, steroids, SARMs, all things testosterone for men, but you women will benefit as well. I admit and talk about my own testosterone use using steroids in college. And so I've had a hard time getting my levels back up naturally. So in searching for natural remedies, I had heard many different people talk about the Joovv photobiomodulation tool. I was skeptical, just like you probably are, so I tested my blood levels before buying the device and then using it every day for 90 days, and I retested. To my surprise, it more than almost doubled my testosterone levels. Now, it may or may not have that same effect on you, but I will tell you that my wife does this every single morning. Her libido's great, her skin's great, her energy's good, she has a six-pack. You know, this is something that she would not take out of her routine. And her patients even notice her skin health has improved. So it's a great tool. I recommend it. You can just start out by getting their Joovv Go unit, which is portable. You can do spot treatments on that. You can see if it's something that you can, integrate into your life and start that way. So links are below. The website that I would encourage you to check out is called joovv.com/Mike, which is joovv.com/Mike. So let's dive back into it with Dr. Thomas O'Connor and talk all things testosterone.
I think a lot of people are not aware about how many folks, you and I know from being in gyms and me, myself, I've been open about it on the channel and so forth. First started getting into steroids when I was 19 and stuff. I used to make Trenbolone and Finna in our fraternity house and crap like that. Don't use anymore, but I just want to help a lot of people who have used.
Absolutely.
And so forth. And I think for some ladies who are not interested or don't have a boyfriend that use, they don't know how prevalent it is.
We have to talk about it.
12 million men?
So the statistical numbers from the data, everything I do has to be initially evidence-based data. You'll read this number from 4 years ago, of about 4 million. But when you really look at how that data was derived, it's very limited. And it's again, there's no criticism on the doctors and the experts that are deriving this data. They're trying to pull this data together because it's so difficult to do because of the steroid users. So I could tell you that the data is much closer to 12 million or between 12 million and 20 million without a doubt, because you can just base it, we talked before, on a fraction of how many people in the United States, how many people do we think from, unfortunately, 15 to 45 that are using these agents.
In high school, we heard about people, maybe I played football and stuff, but you're telling me there's quite a few of your patients.
Every month, I'll take in 40 consultations, that will be ordered. And maybe I'll see 20 or 30 that I'm taking care of my existing patients, and there's new people. So that's the way I operate here in Connecticut and Florida. And over the last 3 years, since I've been just focusing on this as my full practice, coming from primary care, I will do on a month 3 patients, 3 to 5 that are men that are under 21, and they come in with a parent.
And so they bought something on the internet, tried it.
It always starts off pretty much the same way. They're interested in the physical performance, but not for football in America. And this is, again, America. I work more and more commonly outside the country, in Australia, South America, Europe, Asia. They're there too, obviously.
Yeah. Canada too.
A lot of guys in Canada.
Some gyms out there, these guys were all on gear. I was like,
Canadian
is it
guys.
Easier to get gear in Canada?
No, it's the same.
Yeah.
The docs in America are definitely coming forward more than the Canadian guys are. But I talked to a couple guys up in British Columbia recently. Awesome, man. I want to end up there. I'm a mountain biker, so I just want to retire up. If I disappear, you'll find me up in
Whistler or something.
You better believe it.
Well, I'm in Seattle. We'll mountain bike.
That's awesome, man.
Yeah.
So, it starts off always the same way. The kid, the young man, because of the social media and his own interest and really his body, again, not competition sports. That's an anomaly. It's wrong. Disconnect it. Those people, those experts are out to lunch now. They're doing it for the body to feel good and look good. And they start off with supplements from GNC. Test boosters. Can you imagine a kid who's 16 years old? Imagine this. He's going in GNC and he's looking at the test boosters. You're 16. Yeah. You're not boosted enough. But they don't know. So then they get in the test boosters. Then they migrate, or they will transition to pro-hormones, or this the whole gray area of peptides, SARMs, right? And then over time, a certain percent will end up doing oral steroids, Anavar, Winstrol, oral Winstrol, right? Anavar usually, or they move then, X percent. Again, it's this kind of bobbing, weaving. They'll just start to go into sooner or later intramuscular steroids, right?
Interesting. And so I actually read that Anabolics Bible back in 2001 before I did my cycle. And I was always taught that whether it's oral, injectable, whatever, or even the pro-hormones, are going to shut down endogenous levels anyway. So my thought was why screw around with some pro-hormone over the counter? If I'm going to do it, I'm just going to really do it.
Absolutely.
But do you think a lot of men come to see you or go down that road because they buy something retail that's legal, a supplement, it shuts them down, and then they're like, wow, I feel worse than...
Absolutely. So the number one risk of anabolic steroids is up in the brain. It's called anabolic steroid-induced hypogonadism. That's what I'm famous for. And this has been years and years now, over 10 years for me. And the experts are there too, ASIH. So the hypothalamus and pituitary, very sensitive to androgens. It doesn't care what it comes from and if it's federally regulated or not. And if the agent has a clinical effect, if it does work to any degree, it's going to have an impact on your central nervous system, and that's what this is. So there's your answer. Mm-hmm. It does. And then again, they come on and off, and I talk about this all the time. It's the most common question the experts, people ask me, how does it affect? At what point do they end up shutting down or affecting their hypothalamus pituitary gonad axis? And it's a slippery slopeism. It's just the nature of how it works. So guys, they get into it, they do a few of these cycles, and then it's a bad analogy of marijuana to heroin, this kind of transition. But it's an analogy that guys will try it, and it's sexy. They feel it. It works. And who doesn't want to come off? Who wants to keep going? So it's a stepwise progression.
Is there an individual difference in how many men can just bounce back? Say they suppress it, whether it's through steroids, oral, injectable, or pro-hormones. Some people tend to bounce back quite normally.
Absolutely. Okay, fingerprint. Any medical issue. It's across the board. There's variability. Hypertension, diabetes, any depression. No one's all the same. So men, I'm amazed at the variety of the clinical response across the board of, I've heard men say they took 1 tablet or 2 tablets of Anavar and they were shut down. No, it's probably a man who's looking for something else, you know, who has maybe a psychiatric issue. Again, but I'm very careful not to disparage or discriminate. Sure. But then it will commonly come to where a man does 1 cycle and he's shut down, and that's unusual, you know, even so. And then you hear men that have done cycle after cycle after cycle with suppressive drugs like Tren, equipoise, huge doses of test up to 1 gram or more a week. And they come off, they tell stories, and I've even seen the labs where they come off and the levels are 400 or 500.
Wow, that's incredible.
It's incredible. This is why we need to study this in the world. It needs to be academically pursued. It needs to be evaluated. This incredible system where anabolic steroids affect the central nervous. It's all the central nervous. This doesn't matter. This is useless. This is, of course, skeletal muscle. How do these drugs affect your brain? And that's why men come, because of the after effects, the crashing effects. Right now, I'm working with 2 men in 2 hospitals in America, in North America, that have they came off steroids and they've crashed, and they tried to commit suicide or they had suicide ideation. And I'm working with inside the hospital with their family and the psychiatric doctors right now.
That is so cool that you're able to help them, because traditional docs would just say, we'll just keep you on. Instead of like trying to re-kickstart the whole HPA axis, they'll just say, oh, you need to test cypionate 200 milligrams every other week. It's
well, if they even do that, that would be great. They don't even do that. We're coming a long way. The docs are coming home. Great job. Kudos to the docs, you know, because they realize that there is suffering going on, and you can't transfer unprofessionally to a patient because you're upset because the patient just looks great, and grow up. You just can't do that. That's illegal now. I mean, that's unethical.
Yeah.
If not illegal, that you're going to lose your license, because if you can help a patient and you say, get out of the office and get off steroids, and he goes out and commits suicide, I've been through a dozen of these. Stop steroids, get out. You'll be okay. That man is at high risk. If he has an underlying mood disorder, he's at risk for killing himself. I've seen it. So doctors have to be, if you don't want to lose your license, you better understand the data that you have to transition this man. And you have to offer him the ancillary agents, which is really medical grade PCT, right? We could talk about that. And or weaning doses of esters of testosterone. And it's based clinically. Yeah. It's based on the man and his presentation.
Right. And everyone's probably a little bit different on the dosages and so forth.
Are you kidding? Yeah. I mean, there's some generalizations. I've taken, thousands of histories now since 2003, when I became the anabolic doc in my residency at 3 o'clock in the morning.
Nice.
Yeah.
Yeah. That's amazing.
Yeah.
These different drugs, Anavar, we talked about equipoise, Tren, all that. Were they designed to be used in animals? Were they originally designed to be in humans?
No. Well, Tren is an animal steroid, trenbolone acetate, correct? You're testing me, right? You're testing to see if I'm...
No, I was just curious. No,
you're testing to see if I'm the bro science. Well, I'm the lead bro scientist in the world. Let's see if I know. Yeah. So, trenbolone acetate is the cattle Tren, and then there's parabolin, which is really was for human use, and then all the other steroids are for humans. Of course, equipoise is for
horses, right?
Yeah,
something like that.
And if you look at the steroids, which when you look at Bill Llewellyn's 11th edition book, which is incredible, Bible, that's the book. You look at that, and he has the photo library in the back, which is incredible. And then when mothers and brothers and sisters and doctors look at it, and they go, the first thing they say when I meet with these people is, it says for horses, dogs, and cats. I mean, a lot of the drugs, Winstrol V, I mean, it's veterinarian Winstrol. Equipoise is obviously a Latin term for a horse.
I see.
Equine. Equipoise.
Equine, yeah, that makes sense.
Yeah, so,
wow.
Yeah.
So a lot of them, but I had heard, at least for Dianabol and Anadrol, that they were used for AIDS patients. And so, is there any, basically what I'm trying to figure out, does any realm of conventional medicine use any form of androgens?
So let me real quick about Dianabol. I just did a video on Dianabol. So the history of Dianabol goes back to the 1950s with Dr. John Ziegler. He was an Olympic coach, and he was at one of the competitions, and he saw the Russians. It's always the Russians. Saw the Russians, even back in the 50s, and they had urinary obstruction. They were on a lot of testosterone, not D-ball, and they were having problems. They had to supposedly be catheterized because they couldn't pee, because their prostates were enlarged from the androgenic side effects of testosterone, right? Which I suspect, because it doesn't really happen. Even huge doses, you don't have young men being obstructed. So there's something wrong with that story. But he went back, and with SIBA pharmacies, they put their brains together, and they came up with a less androgenic, more anabolic oral agent called Dianabol. And that's the beginning. So that was used for muscle wasting. They actually, over time, in the next 15 years, the federal government in America asked for data for why are we using it. Even then we're scratching, because again, there was no steroid cheating. It wasn't there yet.
Yeah.
That lexicon didn't exist. There's no cheating. It wasn't cheating. It was, let's just, if you could take something and better athlete, this was right, great. Ziegler regretted what he did. Kind of like Einstein regretted the atom bomb. These are genius men that did something, the huge impact in the world. And the initial impact and the concept was to help. And then they realized it was abused. So subsequently, it was removed from the market. I believe 1983, the feds pulled. And then it wasn't 10 years later until you have all anabolic androgenic steroids, including testosterone esters, as classified as a controlled drug, which they are today. So the use and utility medically for these agents are as follows. TRT, testosterone replacement, for hypogonadal men from 18 and above, right? And the reasons for hypogonadism are varied, including now anabolic steroid-induced hypogonadism, which is funny enough, by the experts in the world, they're finally listing it as an etiology for why you have low T. Otherwise, they're looking at diabetes, congenital, so on and so forth. Medicines.
Pituitary tumors.
That's right. The classic, everyone's still looking for that adenoma, that pituitary adenoma. Again, I'm not disparaging. This is all I do, so you see it over the course of 20 years as a physician, and like, that's interesting. And now you have to have the most common cause of hypogonadism in a man who's under 50 in America is from steroids. It has to be, not guaranteed. I mean, so that's what we see. So the medical utility is for TRT, and then it's for cachexia. It's called cachexia. So wasting, AIDS wasting, classically, right? You're wasting away. Burns. People don't understand that you can use Anavar. It's actually indicated. I actually called a doctor years ago. The patient that was on TRT had massive burns all over his body from a horrific incident. And the wife called and said, please tell the doctors in the ICU they're not giving him his testosterone. I called up and I had a great talk with the doc. Benson, Grady Burn Center in Atlanta. Kudos to these guys. Doc was very receptive to me, and I said, please start his testosterone and give him Anavar. He called me back and he said, Anavar is indicated because it's so cachectic. He's so catabolic. So you're burned. So burns. It can be used for any other condition of cachexia, which is a muscle wasting.
Cancer, maybe.
Yeah, but you don't see it though. And that's probably a problem because of the politics and because of the discrimination, because of this global discrimination across the board from Major League Sports. They've poisoned it. And that's why we need to study it and need to appropriately use these drugs. Diagnosis, etiology, monitoring, but you can use these. And we're wondering, why don't we have SARMs, a selective androgen receptor modulator? The woman's 75 or 95 and she falls and she can't get up, not to mention a man. Why can't she get up? Age-related sarcopenia. She's weak, her legs are weak. Why are we treating this? Again, have to be humble, have to understand. But there is an effect of the muscle building. Why would we disparage it and discriminate it when we could use it? Again, I'm not saying steroids should be used by young men. I'm not saying that at all. I'm saying, why would we not look at the positive attributes? Alcohol is used.
Marijuana now.
Marijuana's not used now. We use narcotics. We're missing the boat.
Because there's a stigma that it's just for vanity, aesthetics.
Absolutely.
That's too bad.
Absolutely.
I definitely want to get into SARMs, but before I forget, because we did mention Anabol, is there, if someone, and we're not promoting steroid use for young men or anyone, but if someone was to do an oral agent, because a lot of people do stack test with Anabol or Anavar, some people want it. What's the safest oral agent? And then would you stay away from the C17 alkaloids like Anabol?
So I have to be very careful, obviously. I'm a medical expert. I'm the #1 expert on steroids in the world. So with that said, what's the safest oral agent? There is none. Well, what's least toxic? Everyone knows it's Anavar. I mean, it's going to be Anavar or on a dose-dependent phenomenon. It's a little bit of the oral agent, right? And then it's based on who are you. If you have liver, if you have hepatitis C and you're active and you're using an oral steroid, boom. I mean, so see how important that is? So the toxicity of the oral agent is based on who's using it and what is using and how long.
Yeah,
right?
That makes sense.
And in concert with other drugs. What other drugs? I mean, this is called polypharmacy. This is classic polypharmacy. Many drugs used at once. So that's the answer. You know, there are, the oral drugs that are weak, that if they're not used, Anavar, 10 milligrams.
Yeah.
Right? No one uses 10 milligrams. Or maybe women do.
So, yeah, a lot of fitness.
And it will work. You know, oral Winstrol. But then we know it weakens tendons. It's a drying agent. And all these amazing, characteristics of the bro scientist world, which is what I've initially looked at back in the 80s, 1990s, when I was in the gyms myself.
So you wouldn't, would you advise anyone, if they're thinking about doing a cycle, to stay away from the orals, or just make sure that you really look at their whole health? And
I have to advise them not to do a cycle, because at the end of the day, the cycle is going to end up doing another cycle and then more cycles, and then you're going to come home and you're going to be a patient of mine or another doctor, because your brain's going to shut off, or worse, you're going to have a heart attack. I have multiple men now, status post bypass surgery. I have a few men going for heart transplants. I have men on dialysis right now and men waiting for transplant kidneys. It all starts there. It all starts with that one cycle. Yeah, so I have to really advise against it, and especially young men. Young men have to understand there has to be steroid alternatives, and it's really a behavioral piece first. There's not the actual physical steroid alternative, because that's just a semantic, isn't it? I mean, really, it's not. You either have to think in your mind, what are you doing it for? What are you doing it for? Are you doing it because you want this body? And again, I'm not discriminating. And if you want the body, then beware. And then, doc, I did my research, I did my education, I did my studying, and my PCT, and I'm not back. I feel like because we don't know how to do PCT. There's no studies. That's why I'm here. My next move, before I check out of this world, will be sooner or later to do real legitimate studies on post-cycle therapy.
So all the HCG and the Clomid, and you do every other day, that's all bro science.
100% bro science.
Wow.
There's been some small case studies, and everyone knows that, but they're not prospective. They're not randomized, double-blinded, peer-reviewed. This is real. These are real studies that real experts that this is how studies should be done. We're not doing it. We need to do it. It's freakish.
That is crazy.
It is crazy. It's absolutely insane.
10 to 12 million men are taking all these, and they just go to the forums, anabolic forums. There's a bunch of
all forums.
That's crazy.
2018. This is December 3rd, 2018.
Yeah.
For the record.
It's crazy. Yeah, it's nuts. Going back to, and I think that's brilliant advice, just don't start, because once you start, you become way stronger. I mean, it's like night and day. I mean,
The brain will like it.
Yeah, your ego gets wrapped up, and then your identity changes. And then is that kind of, it's not physically addicting like heroin maybe, or opiates.
It can be, but it's more psychologically addictive.
Psychologically.
Yeah.
And then so you advise people to first like work on yourself, meditate, do other like.
Well, and to correct that, it actually, once you've done enough steroids, it's absolutely physically, because there's a withdrawal syndrome. So I just want to correct that.
Sure, no, I think that's brilliant.
Yeah.
Because your levels are going to be suppressed.
Yeah, 100%. And then so you can't tease out the psychiatric from the physical withdrawal. You can't tease it out. And that's what I work with all day long. I mean, every day, it's all I do. teasing this out and dealing with the medical consequences, which always end up starting with the the psychiatric, depression, anxiety, the mood, the sex, the libido. It's incredible, absolutely incredible.
Yeah, I can imagine. Now, why is it that the kidneys, liver, heart, why are they uniquely susceptible to
Okay, so let's go into my endothelial aspects. So I'm a board certified internist, and I started off my career 25, 30 years ago loving exercise physiology. I think that one right there behind me. So graduate degree, and I went into a PhD. I wanted to be a scientist with preventing heart disease. And then, so I was always involved with exercise, obviously, you could see. So from that standpoint, I learned a lot about what's called endothelial medicine, which is
I noticed that, yeah.
the inner wrapping of the artery. This is a model of normal all the way through to disease. And this is heart disease, #1 cause of death in America. So it's a multifactorial process. Hypertension, blood pressure, cholesterol, diabetes, smoking, you name it, genetics, family history, being a man is worse. So how do steroids lead to heart and kidney disease? That's my most important, I think, overall, what I love to do with, because I'm an internist. So I can deal with this. So anabolic steroids multifactorially affect your body physically. And when you're young, you'll laugh. You're a freight train when you're 23, 33. Depending on, I have guys that are in their 20s that have heart attacks. They had horrible genetics. It's it. Most guys don't. Most effects we see in the heart and the kidney happen over 20 years or so. It takes time. So what are these mechanisms? Steroids increase blood pressure. If you go to McDonald's and you have bad food and salt, you're going to have hypertension. That's going to hurt your heart over years and kidney, right? What else? Steroids affect the lipid panel. It can increase the bad cholesterol and it can degrade the good cholesterol. Should we keep going? Hypertension, dyslipidemia, iron overload. Wow, that's one of my great videos I did. Erythrocytosis and polycythemia on decadurobilin and equipoise. That's clickbait, because I just had to put those because no one else would watch the goddamn video. But it's on testosterone too. And I see it on common men, polycythemia. So that's in there. That leads to a hypercoagulable state potentially. We don't even know. Again, more studies. So this study of steroids, the physiology and the pathophysiology of anabolic steroids is what I do. It's real internal medicine. It's not anti-aging. That's pathetic. Don't have a heart attack, sir. You don't want to anti-age. So that's how steroids affect the heart. But I could go on for 2 hours on this.
There's a lot.
But the basic pieces is that steroids worsen the classic cardiac risk factors, right? It accelerates it. And I see it. All men on steroids, except for a very few, have progressed heart disease when they come in. Enlarged hearts, LVH, and they have plaque in the artery. So I check for all this. Doctors, do this. Watch my 4-part series on how to take in a steroid user. History, physical exam, labs and studies, and management. I did it. I just finished the 4th part today, this morning.
That's awesome. Yeah, your YouTube channel is loaded with great info.
Yep.
I'll make sure that's in the show notes and everything for people and everything like that, which is great. I had this kind of theory that let's say, Mike Mutzel, not on steroids, can squat 300 pounds. I get on, moderate, let's just say 250 milligrams of test and theta a week. I can now squat probably 415, right? Maybe something like that.
You go up, it goes up.
Maybe higher, yeah.
You won't get weak.
Right, yeah. So is that going to put another burden on the stress? Maybe my heart's only designed to pump as much blood. So I was wondering about, because we see with powerlifters too, their heart, left ventricular hypertrophy, you mentioned congestive heart failure. Yep. Is it part of the workload too? The heart's just doing more work? No
one knows. There's so many variables. There's a study last year, 2017, in Circulation by a doctor at Harvard, and he showed that steroid users had increased left ventricle size, and they had a reduction in ejection fraction, systolic dysfunction. That's heart failure, guys. And then we actually know that there is an early diastolic dysfunction. Again, this is really medical. It's really true. So where does it come from? It's multifactorial, and there's genetics on it. If a man has a propensity for early heart disease because he has a father that has it, probably wasn't on steroids, right? The dad's probably not on steroids. Although this day and age, the dad will be on steroids. The next 20 years, your dad will be on steroids. So it's multifactorial. The steroids, they cross the blood-brain barrier. Steroids cross the skeletal muscle barrier, obviously. They cross the myocardial border and they affect the heart. And there's tons of animal models on this now. So under a heavy load, you can get in a large heart anyway. That's the athletic heart. That's not that, oh, it's just an athletic heart. Wrong. Talk to the experts in the world, Dr. Paul Thompson, the guys at Harvard. An athletic heart will remodel backward. You hope. It's not normal. But now you put the athletic heart, this is what your question, you're asking this question. Athletic heart from the afterload increase of intra-abdominal pressures and thoracic pressures, squatting and training heavy, when you Valsalva and you train hard, correct? And then you put that on steroids.
It's going to hypertrophy.
Come on. So this is why I'm trying to treat these men. And another part of my practice in my mind is I'm trying to block these effects on the heart, which I've come up with protocols.
Oh, nice.
Absolutely.
Donating blood or?
No. ACE inhibitors. I've developed protocols for real cardiac medicines. And to block never to give a goddamn blessing on steroid users.
Right.
But what if someone smokes? You ask them to quit smoking. They leave the room and nonetheless they smoke. Do you throw that goddamn patient out? You love that patient. They're diabetic, they're eating, they're using drugs and alcohol. Do we throw them out of the room? No. We protect them. It's ethical. We took an oath. There it is. First, don't harm someone. Hippocratic oath. So I've developed protocols to protect men that are on steroids. Of course, I always want them to come off steroids. But and they're not controlled drugs. This is not my testosterone regimen. That's for the brain. My regimen is to protect your heart from further enlarging or from developing further plaque and having a heart attack. I've developed those protocols.
That's awesome.
With cardiovascular drugs,
beta
blockers, cardiac selective beta blockers. I'm not saying names. ACE inhibitors, ARBs, early diabetic agents. Oh yeah, and they work. But they have to be man per man.
Totally.
And I need
individualized
studies. Apps. That's what I do.
Yeah.
That's why I'm
amazing.
Pretty busy, man.
I love that. No, that's great.
Absolutely the right thing to do.
Totally. I think most doctors need to hear this message because, like you said, I mean, we would mitigate a diabetic, give a diabetic insulin lowering, maybe metformin if they're going to McDonald's, but we just poo-poo the steroid users, say, you can't be in my practice.
Thank you, Mike.
Yeah, that makes a lot of sense. Is there a cutoff point where it's like, this is TRT and then this is a cycle?
That's a great question. Well, you're hitting all the great questions today. I knew this was going to be good.
Nice.
You know, what's that line between steroids? I mean, let's face it. Testosterone, the number on paper is, this is total. Forget the free. I can go in for an hour and, 10 hours. Total 250 to 1100. LabCorp, Quest, whatever, from all over the world, whatever you want to use. So if it's over that, but is it super physiologic? I mean, did you go to the lab 2 days after the injection? Did you go to the nadir? When is it? What are you on? So there is. So there's TRT doses, but I'm amazed at the variability of how men metabolize. I have one guy, no names mentioned, there's no laws being broken, HIPAA laws being broken today. So I have one man who requires 0.8 milliliters intramuscularly injected every other day. The dose is 200 milligrams per mil, right?
Wow.
Cypionate. And so this man, and I started him on my usual 0.5, recovery even dose, maybe a little higher than I weaned down, obviously. Most men are on about a half a mil of cypionate, 200 milligrams per milliliter concentration. I give most men, that Gaussian curve right in the middle, about 90% of them anyway, is half a mil every 5 to 7 days. And you before the standard of care for men on testosterone, I don't care if it's an accountant or it's a TRT or if it's a steroid user, they go to the lab, the nadir, and we see the low point. There's a dynamic up and down. And if you don't want to see that peak, but there's going to be a peak. So this is why I love this question, is that if you took a snapshot of the peak, stop the steroids, bring it down, wean it down, but then, men, you're going like this. So the microdosing comes into play too, right? Mm-hmm. I mean, so, you want to have these small hits to keep it more, so it's really not undulating. It's not, you're taking off the top and the bottom. But then you're a pincushion, you're injecting so much. So, but I deal with this all man per man. Every man I feel comfortable only dosing physiologic. I don't give steroids. I don't want to lose my license. And it's just the wrong thing to do. But men come down to physiologic doses. Then there's a whole idea, the concept about the disparity between the total and the free, which is a whole nother. And that's why the brain feels so good. And the man's brain changes over years because of that free, that high free fraction on the esters.
Interesting. So there's literally like remodeling within the, like neuroplasticity?
There has to be.
Wow.
There has to be. We need to study this.
That is crazy. So then that's what you said. It's like physiologically addicting. But when you come off, you're different. Because
so men, so I have these disclaimers I give to men, and I tell them, if you go on testosterone, you're never coming off because it's going to affect your brain. And these are just virgin men. These are just 45-year-old men or 55-year-old men that have low T because of metabolic disease. They have low T. You know, they've never done a steroid. And I say, well, here's this interesting piece, sir. Say if you're low normal and he wants this stuff, you know. You say, well, the first risk, I tell them, is you're never going to come. What do you mean? My doctor, or I just thought you can just pump it up for a while. No, wrong. End of story. Dusted. Over. You're never going to, your brain's going to love it, probably. You're a man. You know what I say. We're not the brightest bulbs in the tree. So the man's brain enjoys the androgen. You can put it on steroids, is what we're talking about, or you can just give him the regular level. And most men feel well. And what does well mean? You know, they feel better. They concentrate. It is true. The data's there. And their libido's better. And I tell them a side effect is, be careful. I've seen one too many men destroy their life because their libido's too good.
Yeah.
You know what I'm talking about?
Mm-hmm. Yeah. And
they're not humble, and they go out and they make a mistake and they cheat on someone they love, and they regret it. Again, I've been around for almost 20 years, so I've seen all this stuff.
That's incredible. You mentioned something, the microdosing. Would that be like subcutaneous low doses of the esters?
It's subcutaneous or a small intermuscular, but it's teeny doses of, say, we're talking about cypionate, 200 milligrams per milliliter, or enanthate, and it's 0.1 to 0.2, you know, every day or every other day. Mm-hmm. And it's usually just in the top of the anterior thigh. Okay. You know, or even, it can be sub-Q or IM. It actually doesn't matter.
It really doesn't matter?
Nope, doesn't
And
matter.
you like the cypionate ester as opposed to propionate or enanthate?
Well, propionate is short-acting, if it's okay, but in the continental, in North America, I mean, in America, it's just more available. It's testosterone cypionate or testosterone enanthate. They're biologically, pharmacologically equal, people, please. Guys get into this crazy pH thing, and then the most important piece is, to give you a nice answer for this one, is the carriers of grapeseed oil, sesame seed oil. You know, the carriers are more important.
That's interesting.
Yeah, and I work with this, again, I work with this all the time because it's all I do. First I diagnose, and I manage, and in the management piece, I do satisfy men, you know, as far as their sensitivities to administering the androgen.
Mm-hmm. Interesting, really good stuff. Definitely at some point in this conversation, just so we save room for it, want to get into HGH if you're cool with it, and SARMs.
Oh, I'm cool with always everything. I just know how not to answer things.
Yeah. But let's kind of talk about post-cycle therapy.
Let's go.
Again, we're not promoting steroid use at all, but if someone were to do something, you know, there's the bro science, you kind of do HCG and then you clomate every other day, whatever. What do you think is the most legitimate way to kind of kickstart?
So this is not bro science. There's data on this now. I refer you to Cleveland Clinic. I refer you to the guys at Harvard, Baylor. Okay, so it's not bro science.
Okay, good.
It's real science. Post-cycle therapy is real, we call them ancillary agents, and it's legitimate medical therapy for men so they don't suffer coming off of steroids, because their brain is disconnected now from their endogenous testosterone production from their testes, right? They're getting a secondary hypogonadism because the primary is the testicles. The testicles are theoretically, at least in the beginning, in the great beginning, they're really not disabled because they'll wake up from HCG. So that tells you the testicle still works. But in the end of the day, it's a shit show. The whole thing's disconnected. That's why we need studies. So it's a secondary it's a very interesting type, the way it's termed, of hypogonadotropic hypogonadism. Or it should be secondary hypergonadotropic hypogonadism, where the FSH and the LH are up, but the testosterone is down. And then we can go into even tertiary issues with it's above that in the hypothalamus. It's incredible. This is all for the real experts in the world.
Interesting.
Because you have to diagnose, you have to be technical, and that's why it's for physicians only. I've had enough of the nurse. Nurse practitioners are great, nurses, but you have to be an expert on this. You really do. And this is now very serious now. You have to be an internal medicine doctor. You don't have to be an endocrinologist, because most of the effects are on the heart, on the kidney. So do you have to be a cardiologist or a nephrologist? Endocrinologists are great diabetic experts, in my opinion. They're not great at testosterone. It's too complicated.
Yeah.
So PCT, medical grade PCT, is obviously a set of a few agents, and you have to assess it man per man. That's what we do. And then we put together a regimen that will help him. And apart from giving him testosterone esters to protect his brain from suicide ideation,
Right.
and then wean him later, if you're going for fertility and to see if you're going to reboot him, we don't know. It probably won't work. If he's really far into steroid use, it's never going to work. So we do it for fertility. But we do, if a man has just started steroids, yes, we use a combination. I will reference Dr. Michael Scally. Okay. I will reference the William Llewellyn's Anabolics, the 11th edition, because you could see that protocol, which is a combination of HCG, tamoxifen, and Nolvadex.
Okay.
And again, that's the classic regimen. But these men are getting these all from the underground.
Yeah.
They're injecting and taking pills from Asia, from next door. I mean, come on now.
I mean, in someone's bathtub
You
somewhere.
have, literally, not to mention the steroids, you have to go see a physician. Urologist, kudos to some of the urologists in North America. A lot of guys are seeing a urologist initially, and some endocrinologists, and even some primary care and family doctors. Kudos to all these doctors that are trying. They're giving them Clomid at least, or HCG. Great. It may not work. Clomid's potentially very dangerous psychiatrically, because because it's an anti-estrogen in the brain. And this man's brain has already been exposed to huge levels of androgens. Now you're doing a blocking, it just won't work. Again, that's why the esters are probably the best. To figure it out, start the ester, wean down, and then take a breather, address the medical issues, the heart issues, the liver issues, the kidney issues. Stabilize that man, monitor that man, stay with him, and then later see if he can come off.
Yeah.
But after years of steroids, ain't no one coming off.
They're just going to be on TRT for a
cooked.
long time.
Yeah.
Yeah.
I mean, I've seen men of 18 months later, my lowest level ever, 6.7 total testosterone.
Oh my gosh, total?
6.7. Yep, he's still with me. He's doing great.
How did he need a wheelchair to get in? Like,
no, he walked in. He's a warrior. He came in from the war many years ago. God bless this man. And he came in with his wife after he discharged, honorable discharge from several tours, and initially Iraq and minimally in Afghanistan. This is around 2009 or 10 when I first became the anabolic doc with my writings. And he came in from Walter Reed, and kudos to those doctors down there. They did a great job, but they have a lot on their plate. So he came. He said, "Thank you so much, doctors. I'm going to go see my own doctor up in the Northeast."
nice.
He came in with the labs, repeated the labs, and I saw the 6.7. And he came in with his wife-to-be, and he said, "Doc, this is," and he's a good-looking, very good, handsome man, and she was very good-looking herself, very attractive young couple, starting their life after his discharge from serving our country. And he said, "This is my friend, because I have no sex drive, none. This is just a friend. Apparently she's very good looking, but I don't even know what a libido is. It's bizarre to me." Wow. Yeah, so he walked in, and he was depressed, but because he does not have an underlying mood disorder, he had coping skills. You understand that?
Yeah.
So he was okay. He wasn't feeling good. He knew. He said, "I got time. I'm going to get it somewhere. We'll see the anabolic doc." This is almost 10 years ago. He's doing fabulous. He's on TRT. And he's got one kid, because we did a flip off TRT to HCG, and he had a kid. No worries.
Wow, that's amazing.
Like someone said, Ronnie does have 9 kids.
That's a really good point. Wow. Yeah, I think Ronnie
It's not a
Coleman, by the way.
Yeah. It's not Ronnie. Guy, I love Ronnie, man.
What a cool guy.
Ronnie's a great guy, man.
Yeah, he has a lot of grit and tenacity. That's amazing. All right, so we talked about post-CT. Are there other peptides that are higher up, like hypothalamic type peptides that I've heard of people using? I don't know the names.
These are ridiculous things, but it's okay. It's a good question. I mean, the growth hormone stimulators, the GH stimulators,
Heard of, not like GHRP6, but there's other ones for the testicular axis.
Maybe I don't even know.
Yeah,
I don't know. I don't know everything.
Yeah.
I mean, the SARMs, the peptides, I mean, the selective androgen, there's multiple of them. I talk about them all the time. First of all, I have to always start off with studies. In 2018, maybe the end of 2017, Harvard guy, Dr. Bashane, my colleague, did another study. He said there's SARMs out there in the world. Let's even figure out, what are they? We know what they are. You know, Osterin, and there's a bunch of rad ones. There's so many of them, right? I can't keep them straight. So he said, let's buy them. What a study. Published in, I think, Journal of American Medical Association. This is legit stuff, doctors. He said, let's buy them off the internet and see what we get. He bought them off the, you should know this. I was quoted in New York Times with articles on this. So him and this Dr. Bashane and myself, he buys 10 of these drugs off the internet and he analyzes them. Harvard probably has pretty good analyzers, right?
Yeah.
What did he come up with? 50% of the stuff is buckus. The other 50% was just, I think 20% or 10% of the stuff was real SARM. Wow. So we're starting off with, what is it?
Yeah.
Junk. Remember what they said for the old guys, the computer guys back in the 80s? Garbage in, garbage out, right?
Yeah.
Is it like computer science or something? Come on.
So don't mess with it.
I mean, if you really could get a SARM and you use the doses that are intended, but they didn't make the human trials because they cause hypertension and cardiac disease on those doses, but the bro science doses are always 10 times higher. So when 10 years ago, a guy, Osterin, the first SARM, right? One of the first SARMs, I had powerlifter, I have a lot of powerlifters, and he said, Doc, I have an idea. I'm going to do, and again, this is against my advice. I'm going to do, but he trusts me. And I subsequently have weaned him off everything. He's on HRT and he has 2 kids and he's healthy and he's doing great. So 10 years ago, he was on his steroids and he said, Doc, I'm getting ready for a meet. So what I want to do is I'm going to, keep my test to a certain level. And instead of doing androgen, which is dangerous, right, for his heart and his organs, he's going to do Osterin. I said, don't do it. Again, don't do this. Just please stay on your TRT dose and please, oh, thank you, doctor. Okay, so Doc calls me up and he says, Doc, I did it. I did the meet. He'd probably bombed out of this meet, He said, I did the meet and let's look at my blood work because I did test and I did Osterin. I did a lot of it, big doses. I don't know, 50, 100 milligrams a day of it, whatever. And his blood work looked like he was on an oral steroid, like Anabolic. The LFTs were elevated, the HDL was down the shitter.
Scary.
Yeah, so it's like, and I've done this now repeatedly, 100 guys. So, and then we have the stories now of these men that have used Clomid and SARMs, and one guy's blind, 2 guys now blind.
Wow.
There are YouTubers out there. You can Google blindness and Clomid, YouTube. I mean, I don't know, Casey or some kid? I don't follow these people. Ryan Casey or something, he's a big YouTuber. I mean, he said, guys, I did Clomid or a SARM. I can't keep it all straight. And it was either a SARM N plus or mine. He's doing post-cycle therapy off SARMs. That's another thing. Why would you need post-cycle therapy when you're coming off a selective androgen receptor modulator? It's a shit
theoretically.
show.
Yeah.
Come on.
So yeah, don't mess with it. There's surprisingly some health influencers promoting this, and I can't even believe it.
Who?
Yeah, I won't mention names, but yeah, they're.
What kind of health benefits?
Well, to preserve lean muscle mass and so forth, but are not talking about the post-cycle therapy. And I think it's scary to mess with the receptor levels. I mean, what happens if your androgen receptors become downregulated?
Well, they do in that's the anabolic steroid-induced hypogonadal model. So they do become downregulated. They become upregulated, downregulated. In the end, there's what's called apoptosis between the pituitary and the hypothalamus. That's what we know happens. There's a change, there's a permanent change in the central nervous system, in the brain, and they just require testosterone in the end. Again, it's not the end of the world. The end of the world stuff to me is debilitating these men, is saying that you shouldn't be on anything, you're a bad boy. Millions of men, tens and thousands of men are suffering in the corner because men do suffer. Because we are thought to be bad boys in this Me Too movement, and we're all not a bunch of scumbags. So they don't go to doctors. And then it's not an environment, men don't go to doctors, they don't find it a pleasant event. They just don't. So they're suffering on top of this. So they do get downregulation, upregulation, the central nervous system changes, there's no question. And then in the end, they'll need to be cared for in post-cycle therapy. There's no SARM for post-cycle therapy. And in the end, you could quietly put them carefully on monitored androgens, testosterone, normal levels, and they have a great life. They can be fertile, and you protect their heart and their prostate. I don't understand what the problem is.
Yeah. Speaking of prostate, is there a risk of being on TRT and prostate cancer?
Let's talk about the data.
Yeah.
Let's talk about the data. So the data shows us now that men on testosterone have less prostate cancer than men that are not. Yes. Now this is data. So Dr. Morgenthau, let's use the big guy up at, let's use where the research comes from. He's been touting this, and there's data. So the secondary review data. There's no real study looking at an outcome of this. It's all secondary, but it's important data. It's real, and in my opinion, as a primary care doctor taking care of thousands of men since 2005 in my practice, and before as a resident, all the prostate cancer I've seen, except for maybe half a dozen on testosterone, they're all men that have been not on androgen. And now I've seen men for 20 years cumulatively, because they came to me, most men come to me on testosterone for me to manage them. They're already on. And I have to re-vet them, I have to look at their medical history, and it's definitely protective. It appears to be. We got to be careful with the data. It appears to be protective. Now, steroid users, that's a whole different deal, but we don't see prostate cancer in steroid users. And we have definitely just a cumulative, retrospective, multiple sets of studies that go back 20 years, right? Arnold, right?
Yeah.
I'm talking about Arnold. 20
Franco
years,
Columbo,
at
all these
least
guys.
20. There's no prostate. There's no prostate cancer. There's, knocking on wood, there's not heart disease, kidney disease, psychiatric disease, sexual disease, infertility, not prostate cancer. Testosterone saturation model, Abraham Morgenthau. Check him out. He's the
definitely.
one.
That's great. It's in your book too, right?
It's all in my book.
Yeah, which is a great book. That's awesome.
But that's real. These are real physicians. Again, that I try to align myself with my peers. Again, and he's loving. He's very loving and caring. I mean, he's been one of the first, to realize that men on androgens, it's a whole specialty.
I have a controversial question. Well, maybe it can be perceived as controversial. And my Uber driver, I was telling him where I was going to talk with you and so forth. And he goes, a lot of he was like 54 or something. He said, a lot of the women in my life, my wife's friends and so forth, they're on hormones, they're on HRT and so forth. But when a man gets on testosterone, he's cheating, he's a cheater. Why is he doing that? But it's seemingly socially acceptable for women to go on hormones. What are your thoughts about that from a societal perspective, and how do we change our mind there?
Wow. Look at Me Too. Look at this Me Too. Not that I'm not disparaging Me Too. I'm saying Me Too has Me Too been going on just since Weinstein for the last 3 years? We're men. I mean, we're on testosterone from birth. I mean, so, and testosterone is a banned, controlled agent. Estrogen is not. It is interesting, but I also agree that testosterone is very powerful. Is it more powerful than estrogen? I don't know about that. What is your perspective of power? Women use estrogen to feel well, obviously postmenopausally, and for their bones, for osteoporosis. I mean, and they feel better on it. I don't deal medically with women on hormones, only men, and I'm obviously very cautious. So to answer your question, it's controversial, unfortunately, because men are in the shadows. Men don't stand up for themselves. Where are the million men? I want them to come back. The Million Man March. Can they please come back? Where do they go? This is men. I'm a men's expert. That's really, in the end, you boil it down to, these are men in the waiting room, from executives to young men that are sometimes teenagers that they're abusing and using their own hormone. It's incredible. Why aren't we dealing with this? So it is unfortunately biased. It's controversial, because I think men are, the fact that you're a man is you're a scumbag, potentially, right or wrong.
Yeah.
And there is some truth to it.
Totally.
But I tell my daughter, she's 20, Roll Tide, Crimson Tide. She's down there, right? If you go, honey, I say, if you go to have a meeting and an interview with a man in a hotel room, shame on you. I mean, really, this is now, but then there are scumbags out there. There are perverted, sociopathic scumbags. Probably not you, not me. I don't think it's the cameraman over there. Why aren't we saying anything about this? Why aren't women speaking up for us? And most women, if not all the women I deal with, that are the partners of men that I give testosterone, they're very happy for them. And they're happy themselves, as you can imagine.
Totally.
Yeah.
Yeah. And kind of final question here along those lines. For a symptomatic man, whatever the age, say 25 or older, low T, sexual dysfunction, all that, what are the risks of not getting on testosterone from a health perspective?
Great question. So again, the academic risks are men that are older, typically men that are older and they have low T, they'll die earlier. They just have the morbidity and mortality is up. No one could argue that. But it's tricky data. So they're at risk for cardiac disease. But at a certain point it becomes a conundrum. It's a vicious cycle. You don't know if he has heart disease and he's diseased, he's going to have low T, diabetes, low T. But is the low T going to further that's a whole medical issue. So the risks, from my perspective, certainly, in addition to that, are suffering risks. Because if you have depression and you have low T from medicines, from antidepressant medicines, or you're depressed and they've missed your low T, you're going to suffer. So for me, it's emotional suffering and it's wellness suffering, real wellness, not anti-aging, goofy, ridiculous, unsubstantiated wellness. Wellness, pathetic. It's men that they don't come in and pay me money to bullshit me. They can get steroids, and they have been, from the streets, and they can go to anti-aging guys and get whatever they want in Florida.
Yeah.
They come to me because, Doc, I really want something, and they come in with their loved ones. So to answer your question, it's going to be some form of emotional suffering. That's what the complication of low T is.
Yeah. So just overall vitality wouldn't be there.
They don't feel good, man. They're sexier. Your libido. This is what I say. Even men that have normal testosterone, you give them testosterone, they're hornier. They're 20. It's right.
Yeah.
No one's going to argue this now. I mean, the studies are proving it now. Even it's like back in the '80s where the medical studies showed that they weren't sure. The doctors weren't sure that anabolic steroids worked for muscle building. Remember that? Have you heard that?
I don't.
That's true.
Interesting.
Yeah, so now we're at a point now that testosterone doesn't make men horny. Woo! Wow, that's crazy. But the studies do. But it could be too horny. And not everyone horny. And not every man that has low normal T needs testosterone. I have men coming in here because I'm an expert in internal medicine. Doc, I don't want to address my testosterone. It's a little low normal or low. I don't want to be on testosterone. You're the boss, sir. I don't want to give you testosterone. Doc, can you help me with my hypertension, my diabetes, my prediabetes, and my coronary artery plaque, or whatever other medical issue? Yes, I can. So not every man, it's not a number on paper. It's a clinical approach. It involves numbers on paper.
Yeah, that's such a good perspective. And then kind of final question here. For a younger man that's now currently buying steroids on the internet, black market stuff, do you think there's real risks there? Whatever they're cutting it, benzene, toluene, who the hell knows?
Are you kidding me?
Crazy,
I've heard horrific studies. There's studies on this. The pill manufacturers, they don't give a shit. Come on. And I love the guys, and they say, no, my dealer, my guy that I get it from. No, Doc, you understand, Doc, this guy's good. I mean, I know. Okay, good luck. I mean, it's cut with garbage. I mean, who knows? And the abscesses guys get, I mean, is it from the skin breaking, from your staph on the skin, which is a normal, or are you inserting into your muscle, in your body, dirty gear, or gear that has, let's face it, I don't want to make people nervous, but, dangerous, mercury, toxicities, bacteria, you name it. The list is long. And that's the reason why pharmaceutical industries have to maintain standards in America and abroad on whatever medicine they're producing. It needs to be, you ever see an inside of a manufacturing pharmaceutical?
Yeah, it's legit. Yeah, I've worked first in the supplement space, and so similar standards.
It costs a lot of money to maintain.
Totally. Oh, it's all hypoallergenic.
Cleanliness. And these guys, most of the gear in America now, it comes. Let's talk about it. It comes in bulk to the guy who's making it, and he cuts it up literally in his kitchen. They used to say the bathroom. No, he's moved to the kitchen now.
That is so nuts.
That's what it is.
Do you find, I mean, we think like it's all these 20-something muscle heads that are buying that stuff, but executives are buying that
Exactly, 100%. Wow. I got guys, there's no broken laws here for HIPAA. I got guys in America, outside America, that are top traders. I have a few billionaires. Love testosterone. Love it. They're men.
And
They're
formerly,
men.
before being a patient of yours, they're buying it off the internet?
Yeah, all over. Anti-aging, their doctor, it's all over the board.
Yeah.
Their doctor gave it to them, what country it was. I don't know. I don't want to hate on other countries. They're getting it themselves. They're making it themselves. They're getting it. And they're not interested in muscle building. You know what they're interested in, some of these men? Here's a tip for you. It's amazing. Making more money trading. Closing a deal with a handshake. Having confidence, having sex, great sex. These are men that come in this chair and they sit, maybe that chair.
Yeah.
And they tell me, Doc, do I have to bench 400 pounds to get in here? I don't want to be looking like you, Doc. I take testosterone. Ask me why I take testosterone, Doc. Okay, why you take testosterone? Make more money, kick ass. You know, I have mountain bikers, not the pros, although I've talked to a few of them. For muscle recovery from the injuries.
Yeah.
But road bike guys, mountain bike guys, I mean, parasailing guys. I mean, it makes, probably not 25, these are 35 to 55-year-old guys, maybe even older, and this is like TRT. But some of these men even add a little bit of tren for sex. Yeah.
Interesting.
Oh yeah, then the problem is, I'm not telling you to do that, sir, please don't do it. Look at your labs, and then the problem with adding some of these ancillary steroids is if you add tren to test, you'll be horny as crazy. But what do you do when you got to come off? Wow.
Because that's very suppressive, right? Tren, we talked about that.
Yeah, but then your brain on test and tren is hornier. They're on test and they feel horny, whatever that level, 8 out of 10. Then and I'm thinking of some particular case studies that I have. And they add a little, and these are sales guys. They're not, and they're 40 to 70. Wow. And they're adding little baby doses of tren. And their sexual experience is off the hook. And then so their brain, the limbic brain, where the sex area is for us. Remember, we're not the brightest bulbs in the tree. You hit it with androgen, it usually lights up. Women are different. We know they can respond to it too, but I don't deal with women. So in this regard, but then you're up to this. Then you have to come down. Then you pull the tren off, and you're just sitting on test. So guys, I have to wean them. Oh, I don't wean tren. I just say, please stop the tren.
Yeah.
And then I have to then be saddled with a man who's on test, and I can't have him use tren for the sexual experience. And I'm waiting for one man right now, hopefully, to come back to where he was on tren. Wow.
That's crazy.
Sexually. It reminds me of other drugs, the Melanotan II and PT-141. Should I talk about that?
Sure, I'm not familiar.
The sexual drugs? These have been out there forever. They're the peptide sites. So these are the Tanner. Everyone knows this. The guys that are watching know this stuff. We cover the full base here of all the gear. Bro science. These are drugs that are stimulators in the melanotan II, in the receptors in the brain, and they cause absolute spontaneous erections in men, and women too. But they have this funny cough, not a tren cough, and they have other reactions of palpitations and sweating and heartburn. Very interesting. So I'm so amazed at this. But you get spontaneous erections. So PT-141, everyone knows that. And I've experienced over years some of the chemical gurus in the world, right? I've taken care of the gurus, right? The real gurus, the steroid gurus, right? They're called now, unfortunately. And some of them are in jail, some are dead, from homicides and from suicides. But they made steroids. And I'll never forget years ago, probably 2012, when I was writing in the magazine, and I was taking, again, they come into me for medical issues. They don't want steroids. They make steroids. They want me to help their hearts and heal them. So the guy said, Doc, make sure you tell your patients, don't use PT-141 because the brain will adjust to it, and then you'll destroy your brain, and you'll not be able to have sex after utilizing a certain amount of PT-141. And I've heard it's true. I don't think people are using. I don't hear about this drug so much anymore.
That's scary to think about. It's kind of like using ecstasy to go to a party. Like people talk about that. Then when you go to a party, you're like, this is boring.
100% analogy.
You just
Perfect.
blast the brain and change your perception. That's scary.
Perfect. Stay on, don't do anything. And the worst case scenario is stay on just a little testosterone and stay healthy.
Any final, like, we could talk all day, Dr. Thomas. I mean, this is great. I mean, you got this amazing book, America on Steroids. I'm going to put it in the show notes, folks. Really good information.
Yeah, please. The book is, it's. I want that book out there more.
Yeah.
Yeah.
I think,
I want the New York Times bestseller. Why isn't it there? Why isn't it there?
yeah, I mean, there's tens of millions of men on this. And
I walk around Barnes & Noble and I see a lot of other books. They're good books, but why isn't that book there?
It's got to be there.
Come on.
This is the type of book that a young man might order and like hide it from Amazon so parents don't see, because they'll have that perception that he's curious about this.
Wow.
So when I ordered that book, Bible of Anabolics, right? This was in 2002. It was like the first book I've ever ordered off the internet, right? And I remember I came to my house. I was living with my dad, first year out of high school, and I was so like, so he's like, "Oh, you got a package here." I think it was like Barnes and Noble, whatever. I was like, "Oh yeah, that's for this college thing," and I hid it, and I would go to the library up in the corner like this to read all about, you know, DECA, test, all this stuff.
Unreal.
Anyway. So because there's a stigma associated with it, right?
Stigma's come down, man.
Yeah.
Stigma's coming down because I'm just out there in your face and browbeating the world. I mean, how can you not? No one ever argues with me. If you really truly care about the man, why would you not want to properly address him? And then now we know that people say, where are the bodies? Holy shit, right in this office. It doesn't matter. I mean, Rich is dead and McCarver dead. But I don't do those kind of levels of drugs. Really? Well, you'll just quietly die later from heart disease, maybe depression again, kidney disease. The bodies are definitely there. It's amazing. It's amazing what the young body can take. That's freakish.
Yeah.
Because these are healthy freight trains. That's interesting, isn't it? Super healthy bodies that they're destroying their own body, absolutely fully destroying their own body. To be that big, but then there's a slippery slope. I don't do much, I need to, then it's all that. And now I'm from the 1980s and 90s, so it's called a lying man's drug. I remember the 1980s up at Syracuse University, I went to school, I trained in the Townie gyms, some of the strongest powerlifters in the world I've trained with. And I remember no one was on steroids. It was versus today. No one's on steroids. And then you hear a guy, he was on steroids, last year I did, but I came off, 6 months ago. Then a year from that point, you look back in that period, and he said he came off of that. It doesn't ever. You could see the bodies.
Yeah.
But now you can't even tell. Some of these kids, because they just don't have genes to respond, they're on steroids, and they just like maybe they look like a little model. That's the big problem I have now today, is that who cares what they look like? So many men are on steroids.
Do you think that social media is pushing that? Because now, say if I were to do a big cycle, 500 milligrams of tests and DECA, whatever, that would be huge. And I'm taking a bunch of selfies, look at my lifts, I'm deadlifting 600 pounds.
Everyone.
And then you come off and everything deflates. Like it's going to force people to just blast.
Hold on, this is for years now. No one's coming off.
Blasting
They
cruise.
really don't come. Everyone's blasting and cruising. No one's coming off. Or the number of people coming off. And it's always next week, man. I'm going to come off next week. Yeah. I mean, it's just, I've been doing this, again, for over 10 years. And then they finally come into me to come off, because I obviously know how to transition them off. And now I'm teaching healthcare providers with educational videos how to come off.
Very needed, yeah.
Because I'm overloaded.
Right. Only can see so many, yeah. It's amazing. So your website, theanabolicdoc.com, right?
2 websites.
Okay.
Metabolicdoc.com, because you can't see the anabolic doc. But of course, I own anabolicdoc.com, and you'll see that's a URL on my page of Metabolic Doc. It's the anabolic recovery page. So if you Google anabolic.com, that goes right to the page of anabolic recovery. But my main website is metabolicdoc.com.
That's awesome. You got the book on Amazon, Barnes & Noble, wherever books are sold.
Yeah. It's on Barnes & Noble. It's on their site. It's on Amazon. All you got to do is go to Amazon and put in America on Steroids, and it's number 1. Mm-hmm. If you put in anabolic steroids on Amazon, we're up in the top 5 right now, 10.
That's awesome.
Yeah. And that's less than 1 year.
That's amazing. Good for you. I mean, good for you for putting yourself out there, you know, because I think a lot of doctors worry about their license, and I'm not sure if
I did worry. I do worry about my license, but I was already, let's just say I got beyond that hurdle.
Good.
You know, and because I knew you have to do it right, and there's no blessing on steroids. But the heroin, do pain doctors and infectious disease doctors and psychiatrists, do they give a blessing on heroin when they prescribe methadone? Let me ask that question. Do they?
Not
No.
that I know of, yeah.
The anabolic doc, I'm an expert in anabolic steroids. Game on. Men are suffering. They need to be dealt with. I don't give it a blessing. It's not what it's about that at all. And that's widely understood now. In the beginning, anabolic doc, look at him. Don't discriminate on me. Don't profile me. I'm getting attention, which is good for what my intention and my scope is. Taking care of men on steroids and testosterone. I take care of mainly just men on testosterone. Regular guys on testosterone. You don't have to bench 400 pounds to see me. You know, so many guys call. Is there requirements for how many bodybuilding shows I need to see? Only take professional bodybuilders?
Yeah, isn't that funny?
It's true.
Yeah.
And we get hammered with the calls, and it's amazing. But my team can't get them off the phone because they have so much to, and that's why we're opening webinars. I have a webinar series coming up because I can't physically see all the patients anymore.
That's great.
Yeah.
And by the way, are you taking new patients? If anyone listening
Always
wants to...
taking patients.
Okay.
There may be a waiting time, but I'm always going to take new patients.
Yeah.
Always, always, always.
Good for
and
you.
I'm hiring and training physicians, and I'm doing webinars all over the world.
That's
The
good.
webinars are starting. It's called Strong and Healthy webinar
Oh,
series,
awesome.
where I'll
Much
do
needed.
5 men at a time, all private, and then up to 10, and then even more. And then I want to do open forums. I'm going to be doing speaking tours.
Cool.
And
And you've been writing in Flex Magazine and Muscular Development for 10
I've been
years.
writing for muscular development for coming up on 10 years. I started the fall of 2009.
Nice.
And I've been featured in 2018 twice in Muscle Fitness.
Cool.
Yeah.
That's good. Good for
So
you.
Muscle Fitness, Flex and Muscle Fitness have come together as one. And I have all my own media, and I've been interviewed by, I always take interviews.
That's great.
You
That's
know,
good. Spread
because
the word.
it's spreading the word. It's what we have to do.
Yeah.
Thank you.
Yeah, there was some final question I was going to... Oh, yeah. So if someone is listening right now on YouTube, which is our primary channel, what's one video they should watch on your channel to get started? What's your favorite video you've done?
Oh, God. Think about that. There's so many videos that are good. The series, the Steroid Mistakes series.
Okay.
Yeah, watch the Steroid Mistakes. It's a 4-part series.
Yeah, okay. Oh, I haven't checked that out. I saw
Yeah.
one of the first videos I saw was Dallas McCarver's autopsy recovery.
Well, of course. Well,
That
those
was
are the
enlightening.
most famous ones. But I just hit the refresh, and
Tens of thousands of
I mean,
views.
it's crazy. You know, great. It's just insane.
His lungs, his liver, the
Yeah.
size.
So watch Dallas McCarver's video. Watch my autopsy. In the beginning, I was doing this for 2 years ago, 8 years, 10 years now. Since 2003, really, when I became the anabolic doc, when I was a resident, when my colleagues in the emergency room were intimidated by a man. It's on the back cover of my book. They were intimidated by a big man that was in atrial fibrillation, and they called me up in my call room. They called me, and they said, "Come down and see this patient. Your guy's here." And I said, "Who's my guy? It must be a friend of mine in the ER. I better get out of my call room, forget the 5 minutes of sleep for 30 hours, and go down." So I went down, and it was this big bodybuilder. I mean, beautiful guy. I mean, 5'9", 250, ripped, right out of a show, and he was in AFib. And the other doctors were actually intimidated by doing a history on him. They really were. So I took the history, and that's when it began. And I had steroid users coming to my inner city clinic, in Hartford, Connecticut. And then and I graduated in 2005, opened my own practice, and since then been doing it ever since. Mm-hmm. So this is definitely a calling for me.
That's great.
I've been
So needed.
I was born as the anabolic doc.
Yeah.
But it wasn't until 2009 until I bought the .com for $12.
Oh my gosh, yeah, now it'd be way more, huh?
You go, Daddy.
Yeah.
$12. Everything I start is about $12.
That's good.
It's always the way to go.
Yeah, that's funny. Awesome. Keep up the great work. Really appreciate you coming on the show.
Thanks,
it's fun
Mike.
talking with you.
Thank you so much.
Yeah, my pleasure. All right,
Cool,
guys.
guys.
Hope you enjoyed this video. If you did, hit that like button. Share this with a man that you care about or someone that may benefit. And definitely check out the book, guys, America on Steroids. I'll put it in the show note and links below. And hop on over to Dr. Tom's YouTube channel as well. Appreciate you tuning in.